And go ahead, Leah. Thank
Okay,
you.
can everyone hear me okay?
Yes, that's great.
Yes, excellent. Okay, so I think it's high time we had a talk about AAA for AA amyloid, and I think we really need some help at Harborview for our patients with AA amyloid. And I also sought out help for this talk so I really want to thank in advance those that gave me expert assistance, in particular our prior renal pathology fellow, David Enriquez Ticas, Kelly Smith, and our whole brilliant UW Medical Center nephropathology team. So here's where we're going today. Here's my outline. First, we'll talk about heroin. Then we'll talk about heroin in the kidney. We'll talk briefly about AA amyloid in the kidney, and then we'll put it all together and talk about heroin, AA amyloid, and the kidney. So what's heroin? So it's obviously not good. The chemical name is diacetylmorphine, and that's often shortened to diamorphine. And ironically, the potency is about twice that of morphine. Heroin can be injected, it can be smoked, or it can be snorted. And there are actually hundreds of street names for heroin. And I just put a small number here, including Big H, Big Tar, Chiva Heldas, Horse Thunder, and Smack. And heroin can be cut with things, notably sugar, powdered milk, and very unfortunately, and increasingly fentanyl. So I'm not going to talk in detail about the opioid crisis. I just want to make sure everyone is familiar with the fact that different medications confer different ability to kill you. So this is just basically a picture of how much of a narcotic you need to take to die. For morphine, which is essentially one potency, you need to take about a pea-sized amount of powder. For heroin, it's about a sunflower seed. For fentanyl, it's only a sesame seed. And for sufentanil, which is now FDA approved and is 500 times stronger than morphine, it's only 1 grain of sand. So I was very surprised to find out the first sentence here when I looked through the DEA .gov site and went into more detail. And it turns out that most heroin in the US actually comes from Mexico. I was shocked and also dismayed because this goes against what I've been teaching at Harborview for decades, which is that on the West Coast, we have black tar heroin that comes up from Colombia through Mexico. And on the East Coast, they get China white purified heroin from Afghanistan and Asia, and therefore they don't get amyloidosis. So for a number of years now, at least since 2020, if you go through DEA seizures, almost all of it is actually directly from Mexico. And in contrast, most heroin in Canada comes from Asia. So a really big difference here. And then we know that most heroin in Seattle, it comes in the form of black tar heroin. And if anyone's ever seen black tar heroin, our vascular surgeons actually pick it out of blood vessels when they try to place fistulas. It truly looks like black tar. Heroin also comes in other forms, notably brown with some names for that, and most purified form, China white. For those that don't know how patients actually use black tar heroin, what they do is they put it on a spoon, they hold it over a candle or even just a lighter. Here's the needle, they melt it and then they draw it up and inject it. So briefly, in terms of the history of heroin, I want everyone to realize how long narcotics and morphine's been around. So the opium poppy was actually cultivated in Mesopotamia as early as 3400 BC. And then heroin was first produced by a guy by the name of C.R. Alder Wright. He was an independent chemist in London, and he was looking to make actually less potent forms of narcotics. He experimented on dogs using his new heroin compound, not surprisingly with negative side effects. More than 20 years later, Felix Hoffmann, who was working for Bayer Pharmaceutical in Germany, was also trying to make a less potent form of morphine. And instead, oops, it turned out to be twice as strong. And the company named it heroin for heroic. And what they then did was they marketed the stuff under the trademark heroin. And this is actually what it looked like from Bayer Pharmaceutical. You could buy this. It was a non-addictive morphine substitute used for cough suppressant. That was clearly a lie. And in 1924, US banned the sale, import, or local manufacture of heroin. Heroin's not just a problem for patients at Harborview. Many famous people struggle with heroin addiction. This is just a short list. Our own Kurt Cobain and Jimi Hendrix. Eric Clapton gave a lot of money to help people who also suffered with heroin addiction after he was able to overcome it. Jim Morrison, Robert Downey Jr., our own Iron Man, Keith Richards, and Princess Leia, Carrie Fisher. So when I got in touch with Jared Klein, who's our local head of addiction medicine, to talk to him about trying to mitigate the outbreak of AA amyloid kidney disease, he said to me, "Oh, are people still injecting heroin? I thought everyone's smoking fentanyl now." And I thought, oh my gosh, I'm always late to the party. So it turns out that the Washington State Patrol publishes the seizures of drugs, and this slide shows on the x-axis 2002 to 2020 and the percentage that particular drug made up in terms of drug seizures. And as you can see here, if you follow the line in blue, this is all opioids. This is heroin in orange, which has actually gone down significantly over the past several years. And not surprisingly, fentanyl now is going up significantly, as well as other opioids. So the lines crossed about 1 year ago where there were more fentanyl seizures than heroin seizures in Washington State. So another thing that happened in May of 2021 is going to make it much harder for us to really know what sort of drugs are in Washington State. And that's that the state changed the drug possession rules. And so drug possession changed from a felony to simply a misdemeanor. And $100 million were earmarked at that point for the treatment, outreach, and recovery related to the opioid epidemic. And as a result of this, now that simply possessing drugs is just a misdemeanor, the number of seizures have actually just plummeted significantly because cops are no longer just arresting people or grabbing drugs from people for just having them. You have to be selling them or doing something more nefarious. So it's become much more difficult to quantify use and see what's out there. And I do want to point out that Oregon is now the only state in the US that has decriminalized all drugs. So when we see a patient with heroin on the consult service and they have kidney disease, I usually write on the board sort of the differential diagnosis with everyone. And I find it easiest to divide up the differential of heroin and kidney disease into the patients who we see who don't have proteinuria and those who have proteinuria. Those without proteinuria, I'll just go through this relatively swiftly, but often have ATN from rhabdo. They may have AIN from antibiotics that they've been using for abscesses, or even from drug impurities mixed in with the heroin. We see at times a TMA due to hypertensive crisis when heroin is combined with cocaine. And we do see septic emboli and endocarditis, although that's unusually related to acute kidney injury. The more interesting differential centers on heroin addicts who have proteinuria. And AA amyloid is always at the top of our list. We usually make mention of something called heroin nephropathy, and some of the older pathologists may recognize this as usually a form of FSGS. Most of these papers are from the 1970s. And over the years, there was a lot of overlap, likely with HIV nephropathy. So exactly what heroin nephropathy is a little bit unclear. And I don't like to just throw out that term loosely. It's better to be more specific. At Harborview, we see quite a lot of infection-related GN. Even in our amyloid cases, there can be overlap, and that generally does not come from post-strep. It comes as a result of staph infections manifesting in endocarditis and skin infections. We see coviral infections very frequently, Hep C and Hep B. We see HIV manifestations in the kidney and even IgA nephropathy in the setting of liver disease as a result of viral infection. So now let's flip to amyloidosis. When is the kidney affected by amyloid? I think for nephrologists, the important time that we see amyloid in our patients is first, obviously we see AL amyloid in the setting of myeloma and other plasma cell proliferation, such as primary amyloid. That amyloid, as you know, is made out of usually Ig light chains. We can see heavy chain amyloid, and the majority are of the lambda subtype. Today, we're talking about reactive or systemic amyloid, which is a type of amyloid that comes about due to chronic inflammatory state. And in this case, the major fiber is AA, and the precursor protein is serum amyloid A, which we'll discuss more in a minute. The other time amyloid becomes important to me as a nephrologist, especially as I'm getting older and have patients who've been on dialysis forever, is actually beta-2 microglobulin amyloid, which in dialysis patients can cause carpal tunnel syndrome and significant shoulder and other joint disease. But I do want to point out that there are also other rare forms of amyloid, some of which are hereditary that affect the kidney. And these are a number of the primary major fibroproteins in those amyloids. We won't discuss those further today, but just to know that they're out there. So what's a recipe for amyloid? Well, the first thing you need is a protein. And there are more than 36 proteins identified to date now that can undergo pathogenic misfolding and extracellular deposition into what we learned in medical school to be beta-pleated sheets. The other thing you need is substances that actually bind that protein and encourage the process to happen and keep it going. And so today we're talking about AA amyloid. And so our protein is called serum amyloid A, which is an apolipoprotein. It's made in hepatocytes, and it's actually just part of the normal acute phase reaction in all of us. Among the substances that bind that protein, most importantly is one called serum amyloid P. Serum amyloid P is not a fibrillar protein, but it binds all amyloid, and then non-specifically glycosaminoglycans. So in terms of the pathogenesis of AA amyloid, the longstanding thinking has been that in the setting of chronic inflammatory conditions, there's an elaboration of pro-inflammatory cytokines. These interact with the gene promoter for serum amyloid A, and there's a much increased production in the liver of serum amyloid A. This is then taken up by mononuclear phagocytes, where it undergoes proteolytic processing, spit out, and combine with serum amyloid P and glycosaminoglycans to form amyloid seeds that form fibrils that then deposit most commonly in the kidney, liver, and spleen, and very rarely in the heart, to cause the disease manifestations that we get called in the middle of the night to the emergency room to evaluate. How will we diagnose AA amyloid? And so I said to take to remember that serum amyloid P. So it turns out serum amyloid P, again, is not an amyloid protein. It's a small molecular weight protein that can be iodinated. It can be injected, and you can actually locate it in sites of amyloid. And this is actually available in Europe, and particularly England and Australia, where they use it regularly to diagnose amyloid. Unfortunately, I do not think this radio tracer is available in the US anymore, but I wanted to show some pictures. This is a posterior view, so the person's facing away from you. This is a serum amyloid scintigraphy showing the spleen just filled with amyloid, and you can see the kidneys filled with amyloid as well. This is another patient on the right, an anterior view, who had massive AA amyloid in the liver as well as the spleen, and was given experimental treatment using antibodies to serum amyloid P, and a subsequent 1 year later showing significant improvement. But we do not have this radio tracer in the US, so we need to actually biopsy people to make this diagnosis definitively. And so these are beautiful slides given to me by our pathologists. Just briefly, a PAS stain of this pink material that we recognize to be amyloid, literally replacing this entire glomerulus in a patient using injection drugs. An electron micrograph showing the characteristic, I'm going to see 8 to 12 versus 9 to 11, depending on who you read, diameter fibrils, which are irregularly randomly arrayed. And then for several years now, the pathologists have actually offered us immunoperoxidase staining or immunohistochemistry, looking at actually the AA amyloid chain. Here you see it primarily in the glomerulus. This is another serum amyloid A immunohistochemistry in another patient, and you can see the AA amyloid both in the glomeruli and also all throughout the tubules. And finally, a Congo red of that patient showing the characteristic apple green birefringence, both in the glomerulus and in the tubules as well. Um, I show this slide because I want to just briefly go over the main organs that are affected with AA amyloid. This came from a very large series in Australia, actually, but it's very, very consistent with the larger series that have been published. There was a series around 2008 of about 347 patients out of England, and the breakdown here is very similar. And among patients with AA amyloid, the kidney was by far the most common organ affected. Kidney involvement here was defined as proteinuria more than half a gram a day and biopsy proof of amyloid as well. The gastrointestinal tract was involved frequently. The liver involvement was defined as having hepatomegaly and also uptake on a serum amyloid P scan. Heart involvement was phenomenally low. Only 1% of all patients had heart involvement. And I just want to make this point because the House staff will frequently attribute heart problems in our AA amyloid population to AA amyloid involvement of the heart. And it's really important to look for other causes because that really does not happen, in contrast to AL amyloid, where it's quite common. Adrenals were involved as well. And the nervous system actually never involved. Again, orthostatic hypotension, a common autonomic nervous system manifestation of AL amyloid, but not seen in our patients. So footnotes, it is important to note the heart is rarely involved in AA amyloid, only in 1% of the cases, and there have only been rare case reports of amyloid-related neuropathy. And importantly, asymptomatic deposits which do not cause clinical signs or symptoms are detectable by amyloid scintigraphy in organs at a greater frequency than is clinically relevant. In particular, amyloid scintigraphy will light up the spleen almost 100% of the time, the adrenals frequently, and the liver about a quarter of the time. So why do the kidneys fail in amyloid? And we'll get into the clinical realm in just a minute. So there are two possibilities. And on the right is that the amyloid fibers just replace everything and actually cause the majority of the problem. But there's another hypothesis, and that's that cytotoxic precursors, unstable fragments that are not able to become amyloid, actually are directly cellular toxic and cause the damage. And one reason that we really don't know this is that the pathology itself does not always correlate with clinical findings. For example, there are plenty of case reports of serial biopsies showing that the amyloid doesn't go away once it's there, but the patient can actually get better and have improvement in both proteinuria and kidney function. So it's not clear that the amyloid itself, once it's deposited, is responsible for all of the problems. So let's move on and be more clinical. This is the last year published one of the biggest series of AA amyloid ever, or actually the biggest, where they looked at 1,250 patients. They sorted them into those that had the strongest association with amyloid and those who had weaker ones. And I'm just showing the table that shows the strong association. Chronic infection was at the top. And among skin popping and injected drug abuse, that accounted for only 3% of all of these cases of AA amyloid. This was primarily a European study. Other buckets of diseases that cause AA amyloid include chronic inflammation, such as rheumatic diseases, vasculitides, other skin and soft tissue infection, even hidradenitis suppurativa, the gut inflammatory bowel disease such as Crohn's, hereditary conditions. I'll make mention of familial Mediterranean fever, which we'll talk about when we get to treatment at the end, hematologic diseases, and tumors. Okay, so now we're ready to put everything together and talk about heroin, amyloid, and the kidney. So the first question is, why does black tar heroin use actually lead to AA amyloidosis? So there are several hypotheses out there. The first I think we all agree on is that black tar heroin is nasty stuff and it actually scleroses the veins. So patients can't use their veins for heroin anymore. At that point, they transition to skin popping and muscling, where the heroin sits there for longer and can lead to more chronic infections. Obviously, black tar heroin is dirty. It's more likely to be infected with Clostridia than other strains of heroin, and it causes more infections. And then the other sort of more interesting thing to cogitate about is whether there's some component of black tar heroin that's directly amyloidogenic, independent of infections. So what do we know about patients with this disease? So in the 1970s, the first case reports of this condition were reported directly out of New York, so not in black tar heroin country where we live. In 2015, the largest series of 24 patients were reported out of San Francisco. And amazingly, 86% of all amyloidosis biopsies were AA amyloid in San Francisco during this 15-year period of time. Among these 24 patients, the mean protein creatinine ratio was 22 grams and the mean creatinine 4.4. The average kidney size was actually normal, throwing into question how much we can rely on that to make this diagnosis. And sadly, 47% of patients died within 1 year of biopsy. In 2018, the first case control study, and in fact, the largest study of AA amyloid patients published to date, actually came from us, from here. I will say first, I was actually not involved in this study. This is just the visual abstract, which I'll show first, and then we'll talk a little bit about the details. But Brian Kestenbaum was senior author, and our own Bazad Najafian was the pathologist involved. And then Arjun Sharma and Priya were two prior fellows that married and live now with their children. In the middle of the country as nephrologists. So is heroin use associated with with AA amyloid? And so what they did was they looked back at 3,047 native biopsies from that were recovered here in Seattle from 2005 to 2015, and there was a medical record review. And the purpose was to look at whether cases of AA amyloidosis were associated with heroin use. So there were 38 cases of AA amyloidosis for which there was enough information available to make this decision. Among these cases, there was a prior history of heroin use of among 95% of patients. 87% had skin abscesses, 76% were muscling, and 27% were skin popping. And this was interesting because prior to this paper, most of us thought that this AA amyloid only came about in skin popping, but it can come about in muscling as well. What they then did was they chose a control group of patients with other diseases who were matched for age, gender, race, and some other factors, about 2 controls for every case. Interestingly, about 14% of people among the controls were using heroin as well. And the results showed that among patients who used heroin, there was an increased 170-time-fold increased risk for amyloidosis compared to those who didn't use heroin. And in particular, AA amyloid patients did a lot worse than patients with these diseases. They had a 2-fold increased risk for end-stage kidney disease. So let's just look a little bit in more detail at this paper, since it's the only published paper that we have right now, and the largest series to date. So these are the pre-biopsy characteristics, table 1, just to light up. The majority were men, so only 32% women, and significant majority were white. Among these patients, 11% were HIV positive, 26% positive for hepatitis, which was similar to controls. Hepatitis C positivity was 74%. And compared to controls, those with AA amyloid had about 12 grams of proteinuria versus 3 among controls. And the kidney size was significantly bigger than controls, 12.8 centimeters compared to 11.3. When we looked more specifically at the AA amyloid patients, among the pathology that was found, the glomeruli were involved in greater than 50% of glomeruli were involved in 97% of patients. Tubular basement membrane involvement was fairly common, and blood vessel involvement was common as well. Finally, the patterns of illicit drug use and related medical conditions. So any heroin use conferred a 170 times increased odds ratio for AA amyloid. And in particular, if you were using in the last year, as opposed to more remotely, you had a 223 fold increase odds ratio, which is probably the highest odds ratio I've ever seen for anything. So cocaine use conferred a somewhat smaller odd ratio, and the presence of skin abscess and bacteremia were also very important factors. Finally, these patients uniformly did poorly. So over a median of 1.4 years, about 60% progressed to end-stage renal disease and 47% of patients died. So at that point, and even now, I want to go over kind of what we know and what we don't know, and then I'm kind of honored to present some newer data from our pathologists. So the first thing we know is that patients with AA amyloid almost always present with heavy proteinuria, and often, but not always, have nephrotic syndrome, advanced CKD, and big kidneys. I will say the duration of proteinuria is highly variable. Each time I see one of these patients, I look back to see when we first noted any proteinuria. For many patients, proteinuria can be seen 3 to 5 years before, but there are a selection of patients who have what's called amyloid storm, where they had no proteinuria even a year ago and began to have infections and very suddenly developed massive proteinuria. The next thing that we've observed is that biopsies from patients with AA amyloid often have amyloid in all compartments of the kidney, including glomeruli, vessels, and tubules. And I don't actually know whether that's just specific for AA amyloid in comparison to other forms of amyloid. So maybe some of our pathologists can comment on that. Progression to end-stage kidney disease is uniformly swift, but each of us had patients that stop using heroin that can improve and even rarely resolve their proteinuria fully. The other thing we know for sure to be the case is that vascular access is a very big problem for these patients. Well, there's even more of what we don't know. The first question is, why do some people who inject heroin get this disease and others don't? Is the incidence of this disease actually increasing, and can we possibly detect it earlier? Can findings on biopsy predict outcome or chance for improvement? And really, is there a reason to keep doing kidney biopsies on this patient? Very important for me in my daily practice is there a point of no return beyond which stopping injection drugs can no longer help? Because this figures into how we counsel patients. And finally, are there any treatments for this condition? So to address what we don't know, I'm really kind of honored and lucky to be able to present some of these slides from a manuscript in preparation that David Anikas has worked on with our other nephrology colleagues. He shared some slides from a recent poster presentation he gave. And so just follow my cursor and I'll take you through it. Sorry, I'm just moving people's faces out of the way. So first of all, our pathology departments looked back at all of the cases of amyloidosis from 1984 to 2021, so almost over a 40-year period of time. And the total number of cases of amyloid saw during that time was 705. And then come on over here, and I want you to just focus on these little red circles and the little blue squares. So on the x-axis is the year, on the y-axis is the number of patients, and each one of these little circles corresponds to how many patients showed AA amyloid in a given year. So for instance, back here, prior to 2010, there were fewer than 10 patients a year with AA amyloid, whereas things peaked in 2016, where there were 36 biopsies showing AA amyloid. And this would have you believe that the frequency is going down. I would say that our practice pattern has changed and that we're more and more comfortable making this diagnosis without a biopsy. I think all of us would agree that we're seeing every bit as many patients with this condition, if not more with time, but we're just not bothering to biopsy anymore. So the pathologists aren't getting them. So the yearly incidence of AA type amyloidosis increased after 2000, peaking in 2016 at 36 cases, and is now the most common renal amyloidosis in our patient population, surpassing primary amyloid, shown here in blue in 2015. And prior to 2000, we diagnosed 4 cases of AA type amyloid, less than 1 case per 4 years. So follow this red line. There's just been an incredible increase in the diagnosis of this case, in the diagnosis of AA amyloid. On the bottom, the time and years again, and this time the percentage of these among all biopsies. So for example, in 2016, AA amyloid made up an astounding 3% of all biopsies at the UW, native biopsies, which is really quite a lot. The frequency of primary amyloid has also increased slightly over time, but definitely not in the way that AA amyloid has. Another slide from David, where he looked at and to compare among the cases of AA amyloid, how many were active intravenous drug users. AA amyloid was associated with injection drug use in 98% of the cases, of which most had documented histories of heroin injection and associated infections. So among the cases of AA amyloid, 98% were injecting drugs, 97% of those injecting heroin, 66% had infection, and 84% were hep C positive. And this is actually pretty incredible when you think back to the fact that among that large European series, only 3% of AA amyloid patients were thought to have AA amyloid from injection drug use, whereas here in Seattle, almost all the AA amyloid that we're even seeing is from injection drug use. And finally, these patients do poorly, not surprisingly. So the median time to dialysis, shown here in blue, is 1.37 years, and the median time to death is 4.28 years. So how can we help? I'm always surprised that when I explain to my patients that they have heroin disease of the kidney, they're shocked to hear that heroin can affect the kidney. And I'm going to just footnote that's changed in the past year. So among my patients with amyloid these days, they almost always know someone who's on dialysis or has that. I would say prior to 2020, 2021, they're surprised to hear that heroin doesn't affect the kidney. Now, most everyone using heroin knows someone who's on dialysis. Sometimes it's even their husband or wife or partner. So I would put forward that we should try to detect proteinuria early. I think that this can increase motivation to quit if we can tell people that their kidneys are failing or have the potential to fail as a result of their habit. The other thing that's become very important in our population is just harm reduction. One of our nurses runs a clinic on the weekend where she drives around and tries to get people to smoke heroin instead of injecting. They literally give out pipes for smoking heroin. Promptly treating infections, using clean needles. All of that's important to prevent infections and prevent the development of amyloid. And of course, as these patients are progressing, placing a fistula can be life-saving. Once these patients are on dialysis, if they're catheter dependent, they die much quicker. With regard to really specific treatment for AA amyloid, obviously stopping injection drugs and treating infections is crucially important. Just to know, fellows to know for the boards that among patients with familial Mediterranean fever, which is a disease primarily of Jewish people, of intermittent inflammatory events with abdominal pain and neutrophil activation, colchicine has activity against neutrophil inflammatory cytokine release and has been shown to significantly reduce the risk for the development of AA amyloid in this population. And among patients with other chronic inflammatory conditions, anti-cytokine therapy has also been shown to significantly reduce the risk for amyloid. Among experimental treatments, there's among people that study amyloid, there's a saying that you should put sand in the beta sheets to stop amyloid from forming. There was a lot of excitement over a molecule called aprocitentate. In phase 2 results, it seemed to help with fibril formation, but the phase 3 results were negative, and so those studies and the drug have now been withdrawn from study. There's been a lot of case reports of good effects of monoclonal anti-SAP and even anti-AA antibody helping with these deposits. And people are looking at other novel molecules that can disrupt fibrillogenesis. Finally, there's now a transgenic murine model for AA amyloid, which may make it easier for us to study this. I'm hoping to have some discussion, but first I really want to thank all of our pathologists, especially David, who worked so hard on these slides. They've done just a brilliant job putting all this data together and drawing attention to this problem. And I'm going to take their data to our addiction and public health people to try to get some sort of program where there's more awareness, where we can actually do dipsticks and methadone clinics and have patients recognize more early with the hope that we can try to end this epidemic.
Thank you, Leah. Gorgeous presentation as always. Questions for those who can stick around for a minute or two.
Leah, this is Raj. Excellent presentation. First, I just want to acknowledge what Charlie just wrote in the chat, that prior to 2000, much of our senior nephrology leadership at UW were not supportive of doing biopsies for many conditions in general. I suppose a word of caution when thinking of incidents prior to 2000 if biopsies were not being done. I just wanted to acknowledge also the work our addiction medicine people have done in supporting us. I wanted to see whether how that partnership is evolving, because it's not a kidney disease, it's a kidney disease plus. And unless we manage the addiction, our ability to manage kidney disease is very limited.
Sure, absolutely. And I'll be giving a talk to them in early December on amyloid in the kidney. They asked for one. One of the things that Jared brought up was that we should also just screen. It should be part of their screening process when they do an addiction consultation in the hospital to screen for proteinuria. So I was sort of probably a little bit too excited. I wanted to screen for proteinuria in needle exchange areas. His concern is that when you ask someone who's using heroin to give urine, many of them are on parole and other things. And so they're very concerned and suspicious when you start asking them for urine samples that they're going to get turned into their parole officer. So we talked about maybe just having dipsticks available in the bathroom with instructions of how they could detect, and then maybe a phone number for my cell phone or kidney clinic, at Harborview. I thought that would work well. but we're, obviously this is going to take more work. I talked to Jared. I want to just make some kind of handout or literature that we can use at methadone clinics, just explaining that kidney disease is a risk for patients using heroin, so that they, we can just spread the word a little bit more. So.
On that note, in the chat, I was going to add Dr. Bullock's question about what access to methadone and Suboxone is like in Seattle.
I think we have a really robust, our addiction medicine clinic is really robust in that regard. And so, they do a fantastic job trying to get people onto Suboxone and facilitating methadone use. So I think and there's a lot of outreach programs as well. So you don't have to necessarily ask for help. People will come to you to offer help. So, I don't have statistics to give you necessarily, but it is relatively decentralized, but that can actually be helpful. So,
Leah, I have a question about vascular access. Do you have much pushback from your vascular surgeons in placing permanent accesses? We currently are getting pushback in a particular patient case. And until they stop using heroin, they won't place a permanent access. So they have a nice catheter in place instead.
Right. So for years and years and years, that was kind of the answer we got, that if anyone was still using, they would not place permanent access. And there's been, a really marked change in the approach by our vascular surgeons towards a more harm reduction policy that began about 2 years ago, where they're now willing to do it. And I think, I will generally try to they'll generally try to place a fistula. And if they can't place a fistula, they'll ask us if we want to graft. I'm very, 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 very reluctant to place grafts in people that are using heroin because I've seen so many become infected and leading to everything from, brain abscesses to other things. So I pretty much just, I stop right there and say it's just not worth it. There are other providers who are having grafts put in. One of the things is, there are patients who have AA amyloid who've actually stopped using drugs several years ago and have negative urines. And in those situations, I may consider putting in a graft, but anyone who's actively using, I don't. But I'm really grateful to our vascular surgeons for having a new perspective on that, because I think it's a life-saving perspective. So, yeah.
Brian?
Leah, that was a great talk. Thanks for enlightening everybody about this really important topic. There's one question that there's a lot of questions about this that I have, but one of them is when trying to present something out there into the community, what is for a person who is using black tar heroin in Seattle, what is their actual chance that this could happen to them?
So that, that was on my slide that said what we don't know. The first question is, why do some people that use injection drugs get this and others don't?
Yeah, there's the why, and then there's also like the how much. I mean, it could be, I would guess the vast majority of people can use black tar heroin, get multiple infections, and never have a kidney problem.
Exactly.
Which makes it hard to know like how much effort, where to put the effort. It'd be into the quitting or all these.
Right. No, I totally agree. And the fact that now with Washington versus Blake, that they're stopping drug seizures, I think it will be even harder to know, how many people are actually because that's a question I got from Jared Klein, like how often does this, among what percentage of heroin users does this happen to? And so I don't know the answer to that. And I don't know what makes those particular people more vulnerable either. So it does seem like the vast majority have been using for a very, very long time. I always ask everyone, when did you first start using heroin? Recently, a 47-year-old told me my sister gave it to me when I was 12. So, which was just really sad. But I've been impressed at how many started using in their teenage years and 20s by the time this happened. So, yeah.
So Leah, can I ask you a question? I put it in the chat.
Yes.
We pathologists make an effort to put pictures and illustrate the pathology in all of our biopsy reports. Have you found them useful? Does anyone show them to patients to show the extent of their involvement, like those wonderful pictures with the AA immunohistochemistry as a means of affecting behavioral change in some of these patients? I've always had the hope that maybe they were used that way, but I have no idea if they are.
Charlie, that's an excellent question. So it really is a very good question. And I think the kidney is obviously, a very sophisticated organ. And so it's hard enough to explain it to a medical student without explaining what the pathology looks like to a patient. I will, if they had very large, echogenic kidneys, I will show them those pictures and say, your kidney is filled with this stuff. But I guess I haven't actually shown the pathology because I'm just not sure how helpful it will be. I think it will be like looking at a Rorschach sort of ink blot and for a lot of people, but what you're doing is still extraordinarily helpful, obviously, to us. I don't know, have any other nephrologists done that with, certainly I've shown other people their biopsies when they ask for it, but I haven't done that. So, yeah.
I definitely do with my patients in clinic. I feel like even if they don't, I just show them a normal looking kidney biopsy and just say like, this does not look normal. And I think people can appreciate that at least. And I sort of try to like point to the areas. I don't know if they,
Right. No,
but yeah, I think people like.
I think that's wonderful. Obviously, the more we educate, the better. So I have a question from Daniel asking, are you aware of any talks or work on implementing needles? So we have actually pretty robust needle exchange programs in Seattle, and there's even a nurse there that helps with abscesses and things like that. So we have them. What we don't have is sort of safe places for injection use, which is, there've been a number of New York Times articles on that across the country lately, where people can actually go inject in safety. And that would probably or inject in a safe environment, but we have good needle exchange in Seattle. So other
Thank you.
questions in chat. So.
Okay.
Sorry to go so over, Kate.
No. This was going to generate some really interesting discussion. I'm glad that folks stuck around and asked some good questions. All right. Well, thanks everyone again for coming, and I hope to see a bunch of you next week in person. Have a good weekend. Bye.
Thanks. Thank you.